Hi, welcome back to House Healthcare. We now have legislative counsel in with us on S 36, which has been in House Human Services, and they've asked us to just take a look at it because there's a couple pieces in it that, sort of coincide with what we do here. So fly over, drive through, whatever.
Not over the drive.
But not a drive-by.
Good afternoon, Katie McLean, Office of Legislative Counsel. Let me pull up the draft. So this is the as passed Senate version, because the bill is not yet out of Human Services. The direction they were heading in as of a half hour ago, was to keep the language in the bill as is, and add 2 new sections that I can sort of describe, but they haven't voted on those sections yet. So this is a bill, it does a few different things. So the first 2 sections look at how high intensity and low intensity residential treatment for substance use disorder and co-occurring mental conditions is paid for through Medicaid. This first section says that AHS is to provide coverage for medically necessary, high intensity, medically monitored residential treatment episodes to Medicaid beneficiaries with substance use disorder and a co-occurring mental health condition when medically necessary, high-intensity, medically monitored residential treatment episodes are prescribed by a healthcare professional employed by a residential treatment program who is practicing within the scope of the health professional's license, and the residential treatment program participates in Medicaid. And then in B, coverage provided under this section is to be for the entire length of stay prescribed for the healthcare professional employed by a residential treatment program who is to take into account the current best practices for each level of care within the substance use continuum of care. That language is repeated in the next section, with the only difference being this lead-in. Instead of for medically monitored, it's for medically necessary, low-intensity, clinically managed residential treatment. But otherwise, the language is the same. And the committee downstairs, Senate Health and Welfare, was looking at this in relation to how Medicaid reimbursements are for episodes, and an episode is, while it might be less or more than 14 days, they use the average of 14 days to determine what the payment is per episode. Oops, just on my screen. Okay. And then we have a report on this same topic. So in section 3, the agency is required to conduct a review of the Medicaid payment model for residential substance use disorder and treatment services, with special consideration given to the actual cost of providing residential treatment services, commensurate with the length of stay, co-occurring physical and mental health needs, and post-residential treatment service needs. The results of the review are to be submitted to Human Services and Health and Welfare on December 1st, 2025, and the review shall include recommendations and proposed legislation to align the Medicaid payment model with the clinical needs of individuals receiving residential substance use disorder treatment services. And it should also ensure coordinated transitions between residential substance use disorder treatment providers offering varying acuity of care. So I think this is probably less in your policy jurisdiction, as it's more focused on substance use disorder than the co-occurring disorder. The next 2 sections are sort of a change in topic.
Can I ask about
You can.
so I guess as I'm just looking at this language the first time, are they trying to get at the issue right now where you get 14 days and then you're discharged and you have to start a new plan of care? And they're tying it to co-occurring conditions?
I think there are sort of 2 pieces of the conversation. One is that different varying levels of care are not necessarily as linked as they could be. So in terms of thinking of like continuity of care, where services can be provided on maybe one campus, for example, and higher acuity can move right into lower acuity, can move right into different types of services. So I think that was a big part of the conversation, is how to think about, and that's what part of this report is getting at, is how can we think about sort of streamlining that continuity of care? And the other piece was really more about the episodic payment and allowing the person at the residential care facility who's providing the care to determine what the appropriate length of care is.
So episode is an episode. It's not like if you switch, it's not 2 episodes.
I'm not sure I fully understand the question. If you leave, like it wouldn't be uncommon for a person to receive care, possibly step down to a different level or to re-enter the community, and then find that they need another episode of care. And so each episode of treatment would be reimbursed separately.
Okay.
Okay, so these next 2 sections are sort of, we're pivoting in our topic. Right now, there is language in statute that authorizes that if somebody is what in statute is called a public inebriate, so a person who's intoxicated, either alcohol or other substances, and this person needs a safe place to be brought to, a secure location to be brought to while they are intoxicated. Right now, there's language in statute that allows for that person to be held in a correctional setting. There is language, there's this legislative language that was passed, I want to say even 15 years ago, that would say a person cannot be held at a correctional facility. That's not an option. But because there has never been sufficient alternatives and enough beds or programming for this purpose, every year or two, this language is pushed out and pushed out and pushed out. So the language saying that you can't be held at DOC has never taken effect. It is set again to take effect this July 1, 2025. So this language in sections 4 and 5 is from DMH, mostly DMH, I think, is who testified, saying that it would be best, instead of pushing this language out every 2 years, just to repeal the language, meaning that the Department of Corrections would continue to provide a secure setting in the event there are no alternative settings. So that is what this repeal does, is it sort of maintains the status quo indefinitely.
So we're repealing something that never really went into effect. We just kept.
Yes, that's what this proposes to do. That's those 2 sections. And then Human Services is working on language and will likely vote on language tomorrow morning. That has 2 additional sections. One section relates to this, and it's a report back requirement. It's wanting to learn more from the Health Department and Department of Mental Health about what they're doing to roll out more public inebriate services and programming, particularly in Chittenden County. And there's also a report from DOC that would be required. Prior to COVID, there was testimony that prior to COVID, there was more referrals and like warm handoffs between DOC and substance use service providers, and that hasn't happened since COVID. So it would be a report about what steps are you taking to bring that handoff to services back. So that's one section that's proposed and down the hall. And the other section is related to the Human Services Board. That committee was looking at a bill specifically around Human Services Board and decided that in order to proceed with that bill next year, they needed more information to come back to them in the interim. So it's a bill that asks for many different types of information from the agency and from the Human Services Board itself that they would use to help build their bill for next year.
On the section 4 there, the repeal, does that mean that what will happen going forward is the corrections department will house the person safely.
Yes. I mean, that is what's happening now. It maintains the status quo that's happening now, which is that DOC can currently hold somebody, for 24 hours.
Okay.
Yeah.
What would be the alternative to that?
The alternative is that there'd be enough build out in the community that there would be secure beds available to go to keep the person safe until they are no longer intoxicated. So I think the testimonial here is about where the system is and what capacity currently exists.
Any other?
I just can't. I was looking and I can't access the whole thing online.
You're gonna go to the bill. I had the same problem.
What are you trying to look?
Just to read the whole, like, it only has page 1 showing up. And
Oh,
I know I can see it on the screen, but I like looking and it's not a deal breaker because we're not voting on anything. Okay.
I had to go to
probably
the
just a technical glitch.
Yeah, that's why but I mean, it's not a deal breaker. It's just, I'm sitting here like,
And then tomorrow morning, you'll probably be able to see the Human Services Amendment.
okay.
Any other questions for Katie? Thank you. Thought it was pretty important that we hear about sections of this bill. So, hi Beth, thank you for joining us. Very short notice. Did you want to talk about the bill at all? Maybe explain to us?
Yes, please. Thank you. Hi, my name is Beth Holden from Howard Center. I'm Chief Client Services Officer here. Thanks for inviting me today. I did pull as much information as I could in the past couple hours, but I have a long history with Howard Center, so I hope to be able to address your questions. A couple of the pieces I'm hoping to share with you all is that at Howard Center, we did have an Act 1 bridge program. We did have a PIP program. And as I think you've heard in this committee, we are one of the ones that decided to close. And I thought it could be helpful to share some of the reasons why that happened for your understanding of sort of some of the complexities of running a program like this. Is that an okay place to start?
Yeah, that would be great.
So Act
Well,
1.
she said she's gonna refresh.
I'm
I'm
sorry,
sorry?
we've got some technology issues going on right now. But I think are you
Is
all
there
set?
anything that was
I don't
submitted?
have it.
No, I did not submit
Okay.
anything. Sorry about that.
Got it now.
We were trying to pull the bill up.
Thank you, Kristen.
Okay, go ahead, Beth, thank you.
Sure. So I always think the word public inebriate just gets everybody confused, and we call them public inebriate beds, public inebriate programs. So just to remind everybody, like these programs were developed like 30 years ago, right? It was to decriminalize public intoxication. We wanted a safe place for people to recover, sober up. We did not want them to go to jail. We did not want them to go to the ED unless there was a medical reason for them to do so. And I think what's happened significantly, and part of the reasons why we made a decision, there's of course always the financial deficit reasons. So there was not adequate funding to support the program. So for an example, in 2023, we lost $490,000. In 2022, we lost $401,000. And I have a 5-year history I can share with you if that's indicated, but it's a lot of money for us to try to figure out. The second reason was it was COVID, and then we had a huge staffing crisis. Our staffing dropped by about 50%. But the primary reason really is to cope with today's problems, and our current drug supply requires a revamping of what a program like this could look like. I think they could be very successful if supported financially and if we have enough time to do some planning around it. But the days of people just showing up intoxicated is really quite rare. Most people are showing up with polysubstance abuse. Everything has fentanyl in it right now. People have complicated medical problems, not only wound care from xylazine use, but high blood pressure, diabetes. There's very complicated. And a social detox program is not set up to serve that population. It really needs medical oversight. So we would need nursing, we would need doctors. And as you know, those are very expensive services. So I'm hoping it's just not believed, oh, well, there's not enough money for it, or there's a staffing crisis. It's much deeper than that, in my opinion, that a model has to keep up with what we're experiencing today. We also tried to combine, the other part of this bill is combining, and I heard Commissioner Ha's testimony around wanting adult mental health crisis beds and our public inebriate beds to merge. We actually tried it. And so I wanted to make sure people were aware of what that was like. We thought it was a really good idea. We thought it would increase efficiency. Are we not going to need as much staff? We can train everybody in co-occurring. The intention was really quite good. But we found that the mix of populations and the training required really was prohibitive of a successful program. So when you have folks that are in mental health crisis, right, it could be the whole range of things. It could be anxiety and depression, suicidality. A person could be experiencing psychotic symptoms, and a person who's intoxicated behaves in a certain way and might be withdrawing, which is a very miserable experience. If anybody's ever been with somebody who's going through withdrawal, it's watching someone suffer. It's very, very complicated. So mixing those two populations turned out to not be successful because one population triggers the other population. It's not a trauma-informed model. Many of our folks in mental health crisis have a long trauma history. So if they're experiencing someone in the next room screaming and yelling because they're miserable, that's pretty triggering to them. The police showing up, bringing in intoxicated people, that's very complicated too, and triggers people all over the place. So again, we really thought it was going to be a good idea. I think if a DA has one bed, I 100% understand that, because then you can pick and choose what you're doing for that episode, for that person. The other part of that is training is very complicated. And though I agree, everybody who works in my industry, right, needs a foundational education about co-occurring disorders. You need to understand sort of the basic foundation of mental health treatment and substance abuse treatment. When it comes to a crisis level of treatment, we're talking about a whole nother level. We're talking about high risk. We're talking about medical complications. I'm not saying people can't be trained in it, but I just want you to understand that it's intensive and it requires a lot of time. And keep in mind, the folks who work in these positions, fresh out of college students, kids, young people that may not have secondary education at all, right? So we're not talking about master's level clinicians that have gone through a whole educational experience of understanding these things. So it's really the combination of all these things that make it really, really complicated to mix these populations. I was looking at the Commissioner Haas's PowerPoint, and the Rutland program is a very interesting idea because it is a substance abuse residential program. They work 24/7, and they could do detox beds there too. Like, to me, that's a very interesting idea, which is how we initially were set up. But I don't know how you'd introduce mental health patients to that. We also would want every opportunity to be really solid about medication, because this is the other complication. So people are on a lot of medications. Med administration in a DA system is very, very strict. It requires nursing oversight. You don't want mistakes in this area. So to treat people on a detox protocol with medication is very different than treating someone with a mental health disorder that needs regular medication. There's just complexities of how the two populations interact. I don't think these sorts of programs have to live in the DA system. I think there's probably lots of people that could do these programs. I think the medical oversight, I just can't stress enough, which is not the general expertise in what type of staff we have at DA systems in general, and that's true for Howard Center.
Any questions? I don't know, Beth, if you had a chance to look at sections 1 and 2. If you,
I thought I had it in front of me, as somebody else sent it to me, but it was the wrong thing. So I only saw it when you put it up in front of me a moment ago.
oh, that's okay. I know you weren't prepared for that, and that's fine. Does anyone have any questions? Okay, I guess I have one. So Howard Center had PIP beds in Chittenden County, but also in Franklin County.
In St. Albans, that's correct.
In St.
Attached-
Albans.
That, it was attached to our
And so-
clinic up there.
And so those beds have all been closed.
Correct.
So what happens if somebody presents to the emergency department now in either Burlington or St. Albans, Northwest or UVM, and the only reason that they're there is that they just happen to be intoxicated and they're medically stable? What options are there for hospitals to remove them from the emergency department and give them another place to go? Or do they no longer have that option and they have to keep them until the person is no longer intoxicated?
That's a really good question for how the hospital manages it. I can tell you from the Howard perspective, when we get called on people, we might get involved to assess the person in the emergency department. They may call their social worker department. It really depends on the person's presentations. There's really no place for them to go with Act One Bridge closing and the other closing. So I think many try to find safe, healthy adults for the person to go with safely. If the person is not safe, that's when the police might be called and that person ends up in a holding cell, basically in a booking area.
Is law enforcement called from within emergency departments, or is that not a mechanism that they have?
I think it depends on the situation there, because they also have security too. I'm afraid it's probably a better question for them to answer and how they handle that.
Right. We will do that. Any questions for Beth at all? Thank you. Thanks for coming in on such short notice. We really appreciate it. Appreciate your expertise on this. And I think we're done for the day. Thank you, Beth. Thank you. So we
Thank you
can
all. Bye-bye.
go, I believe we're done for the day.
Last thing on the agenda.
Yes.